I'd like to start with something slightly uncomfortable. We know that across Kenya and across the world, chronic conditions like diabetes now account for the majority of long-term claims growth in insurance. If we just take diabetes, it's increasing year on year, and the cost curve is really non-linear. And complications such as renal, cardiovascular, or others is where the financial impact really accelerates. On the other hand, the average diabetes patient only sees a clinician 3, maybe 5 times a year. So that leaves almost 360 days where decisions are made without any structured support. People have to make decisions on their own. And medication adherence for chronic conditions like diabetes drop below 50% within just 1 year after diagnosis. And it doesn't happen because people don't care. It happens because behavior change is very hard. It's not just a medical or clinical gap. And until we address it together, the cost will continue to increase, despite better medication, all the advances of medicine, better guidelines, better coverage. And so what we'd like to do today is really look at what it means to support the remaining 360 days without adding any complexity to insurers or to your provider networks, and really answer the question, can we as insurers and providers really influence the daily drift? Chronic care is not a technology problem. It's often a systems problem. And I think that very few people in this space have seen those systems from as many angles as Amit, across policy, delivery, and scaling models. You have worked across public-private systems in advisory recently and have seen many chronic care problems at scale. From your experience and perspective, where does chronic care most consistently break, especially outside the clinic visits?
From my experience over the last 30 years in both primary healthcare and secondary healthcare, and the services that I see in Kenya, the key aspect has been how to monitor and consistently manage the chronic conditions at home. I think the clinic visits and the specialist visits have been really good in many, many places. We've got qualified staff wherever we have, whether it's clinical officers or doctors or nurses. They do a fairly good job in ensuring that sugars or blood pressure or other areas get treated well. The referral system is something that the country is struggling with. When should you refer to a specialist, and when should you actually get the right kind of care in the right space? Not every diabetic is the same, neither is every hypertensive patient. So that filtering can improve quality a lot, because a malaria case also has its variations. So does diabetes, and so does hypertension cases. These variations is what really differentiates the quality of care at the provider level. So I'll say that there are 3 or 4 breakpoints. One is the referral system as a breakpoint. At a time when this patient's livelihood could be much better and the condition much more easily managed. The second breakpoint that I see is at the household level. I have seen many times cases where, when there is a little bit of a better feel about your condition, the regular treatment either is not adhered to, people don't take it on time, don't take the adequate dose, or don't replace the chronic dose medications which run out. It's that last tablet that they have, and they haven't bothered to get a top-up or called one of the supply chain experts, whether it's a pharmacy or it's a supply institution, and you can lose weeks before they get the supply. So you have that break in between. That's one common reason. The other one is I feel good about my condition and I think I'm okay for now. Maybe I don't need this medication anymore and my blood pressure is under control, or my sugar seems to be under control. I seem to have less polyuria, or I seem to have less episodes of pins and needles, and is an assumption that you're well. And that assumption is not justified by tests, or someone just decides, I don't need to test, I'll test myself with the symptoms being my test. And if the symptoms are less, that replaces the lab. And that then ends up giving complications that the patient can't observe until a later date, where they come into the outpatient with problems on the feet or even dizziness or a coma. And there was that thought that I felt so good. I've taken it for a year or two. I think I should be fine. And I'm actually cured of this condition. And that's one break that I see at the household. I think technology will help. It will not be the silver bullet for sure. Not everyone is going to take onto technology to align them into making their adherence work. But if it does even help a large, significant portion, it would be brilliant. The support structure around the family within the household is critical. Almost having somebody who is a checker, someone who keeps you accountable about your treatment that you need to have. We should incentivize adherence. Somehow we need to loop it in to an entire financing structure where the insurers feel that if you keep your sugar under control, you are great, and maybe your renewal premium can receive some kind of a bonus discount. That would give an incentive, even if it is a 5% reduction. It's like in some countries, you keep yourself fit and go to the gym, and you should pay a low insurance. In cars, they have a no claim bonus. And in healthcare, we should have a health bonus.
I'd like to ask you to maybe dig a little bit deeper into how do you think insurers specifically, or maybe insurers in Kenya, underestimate that risk that you described? So the household risk outside the consultation room, then when they are with their doctor and nurse.
The depth of the insurance industry in the health arena around chronic care household level is very weak. The insurance industry has been preoccupied by the bigger claims for admission, ICU, evacuation, and so on and so forth. And their actuarial modeling of insurance pricing in our country has been around that for obvious reasons. What I think they've missed out, and I hope that the leadership in the insurance industries, especially for the large insurance, where they have now, after many, many, many years, been bringing up healthcare experts into their space, which is a good move, start examining and measuring the missed opportunity of chronic care in primary healthcare. How many more claims they get because of non-adherence and non-compliance. It would be amazing for the insurers to talk about a missed opportunity of reducing claims. You know, you don't reduce claims by just making sure that the patient is discharged on time at the hospital and the length of stay in the hospital is shortened to the minimum possible, or the medications and the labs are minimum as possible. These are all good case management models that they apply. But imagine with a much smaller cost, how many more clients of insurance, of insured clients, would have less admissions had they managed their condition. And we should have a remote patient monitoring model. And this remote patient monitoring model by insurance companies will be so easy to manage. And this is where I think there's an interface between primary clinics that have the technology solutions and the insurance to see the value of this. So I think I haven't still seen a study of the amount of claims leaking from an insurance company because of a weak primary healthcare and homestead chronic management program. But I believe it's high. I'd like to see a real number story of what amount of claims is walking out of the door because of this weak primary healthcare remote patient monitoring at the homestead in Kenya.
We've seen probably at least 10 years of different digital tools, lately AI, globally and in Kenya. And I think you've seen a lot of these solutions at the very start. You work a lot with startups and emergent players. In your experience and in your view, what can digital tools do in chronic care, and what are they not really good at, including AI?
I think any health worker using AI is better than a health worker not using AI. I would actually really find it interesting if we use a regulatory landscape that any health worker that doesn't use AI may not get their licenses renewed, because you're actually delineating and you're cutting down care to Kenyans that are unwell. Slowly after that, I think AI will be taking over more of healthcare workers' responsibility than the worker themselves. So here comes a beautiful solution. Not only will it bring access, but it will improve quality and by far reduce costs, because you don't have to pay any salary to an AI doctor and a nurse that will deliver super primary healthcare. So what it can do, it will actually bridge that divide that we are struggling with in the health systems in countries across Africa. In radiology, we've used teleradiology for a long time, and the AI in radiology have become so good, people thought that we'll have fewer radiologists, but in fact, the contrary. The radiologists now do better than just reading the film, because the reading the film becomes an AI work. The radiologists now become engaged in patient care, managing to read if there's any interaction between neutrophil level, HbA1c, to the uric acid levels, and it should interplay that. That interplay of diagnostic tests has been very weak. You always have people looking for HbA1c or some specifics, but if you take a range of diagnosis and range of different variations, there are very few clinicians who will be able to interplay those tests and give you existing and coexisting factors and complications. The whole compassion space will something that digital may not do, and that human touch that will still be required for patient care. The third one I mentioned was the maintenance part. It's exactly what we're discussing today. Maintaining their health, maintaining their treatment. This is what breaks down at the homestead. How do you have the supporting structure? What kind of information? This might even include developing registers. And this is the sensitive registration data, electronic medical records.
We'd like to move on and just present one practical solution that we developed that could show how it could work with real patients in Kenya. Let's make this concrete. Meet Florence. She's 42 and recently diagnosed with type 2 diabetes. 2 weeks ago, she saw her doctor. She left with clear instructions: reduce carbohydrates, increase activity, monitor the glucose. She understood them. She agreed with them. She intended to follow them. But intention is not behavior, and behavior rarely fails inside clinics. It fails at 9:30 p.m., when she's tired, when she's hungry, when no clinician is present. This is where chronic risk accumulates. Florence is onboarded into structured support via WhatsApp. Not another app, not another password. No new behavior required just to access support. That matters because friction kills engagement before behavior even begins. We ask a few simple questions. Are you checking your glucose regularly? What makes this hardest? When during your day are you most likely to sleep? These are not clinical questions, they're behavioral mapping questions. She tells us evenings are easiest, she eats late, she's tired after work. That context matters more than her lab value because lab values describe risk. Context predicts behavior. This becomes the behavioral baseline, not just what her HbA1c is, but when drift is most likely to happen. And that is where intervention should be placed. The assistant doesn't say improve your lifestyle. It offers two small, realistic options. A 12-minute walk after dinner, or reduce her ugali portion slightly in the evening. One goal, 7 days, no perfection, no transformation. Small, repeatable movement. The constraint is intentional because scope reduction increases follow-through. Later this week at 9:30 p.m., Florence wonders, can I eat rice tomorrow? That question is small, but it's exactly how deterioration begins. Instead of guessing, she asks, using a voice note. The response is immediate, practical, behavior focused. It doesn't prescribe medication, it doesn't diagnose. It translates clinical guidance into a real world choice. Portion control, timing, pairing with vegetables. Most risk decisions are made when no doctor is present. The goal here isn't perfect decisions, it's reducing drift in high frequency moments. Florence reports that her high readings are happening in the evenings. This pattern matters, not because of one spike, but because of repetition. Complications are rarely caused by a single high reading. They are preceded by months of uncorrected patterns. Even imperfect self-reports, when repeated consistently, provide trend signals. Florence reports blurred vision and fatigue. The system doesn't suggest medication changes. It flags risk. It prompts escalation. A doctor will follow up. This prevents silent deterioration. Escalation increases early intervention. Early intervention reduces late-stage cost. Most expensive claims are not sudden. They are late responses to early signals. One evening, Florence uploads a photo of her dinner. Rice, chicken. The assistant doesn't shame her. It doesn't provide a lecture. It makes one simple suggestion. Reduce the rice slightly tomorrow and add more greens. One correction, not 10, because too many corrections reduce follow-through. And in chronic care, precision is less important than repeatability. Over time, small corrections compound. A slightly smaller portion today, a slightly more balanced plate next week. These micro adjustments flatten risk curves, not instantly, but gradually. And that gradual stabilization is what shifts long-term outcomes. Periodically, Florence receives short interactive quizzes, not to test her knowledge, but to prevent disengagement. Behavior change decays without repetition. Even the most motivated patients forget. These quizzes serve three purposes. First, they reinforce key concepts. Second, they create a micro pause in her daily routine. And third, they signal continued mental engagement about the topic. And engagement is not measured by app downloads. It's measured by message volume, by behavioral consistency. In prevention, continuity matters more than intensity. 2 weeks later, the system checks in, not with a lecture, just a structured question. How have your readings been? Mostly stable, sometimes high, often high, not checking. This is where most systems go silent and where behavioral drift begins. Regular check-ins create early course correction. Florence selects sometimes high. She's invited to record a short accountability message, not to us, to herself. She says, I want to stay healthy for my children. I will walk after dinner this week. This may seem small, but self-articulated commitment increases follow-through. Behavior change is not just informational, it's psychological. When people state intention in their own words, adherence improves measurably. The solution intervenes at the drift stage, not at the complication stage. In a 6-month pilot, we measured trajectory shift. Claims impact follows stabilization. Nothing in this journey is dramatic. That is precisely the point. Chronic deterioration is rarely dramatic until it becomes very expensive. The objective is not perfect compliance, it's to stabilize risk. And structured daily support between visits is how this stabilization begins, quietly, repeatedly, predictably. And so now we'd like to make it even more practical. How could this work for you and your patient population? So it's really not a replacement of your network of providers or of your care model. It's more of a daily support level that is structured between visits. The way we approach partnerships is that they're structured, very time-bound, and have specific agreed metrics so that we all know what we are achieving. We typically partner around a very defined, clear patient cohort as well. So for example, it could be just diabetes members, or they could be diabetes members who are at high risk, or a cohort consisting of people who have both diabetes and hypertension. Typical cohort size where we can actually see population level results would be around 500 to 1,000 members. And then the launch timeline is around 3 weeks. There's no complicated IT integration at all. After 3 months, we typically do a midpoint review to review the metrics, patient user experience. And then we do a final evaluation at 6 months. Now, what does it look like for members? Very straightforward. They're invited on WhatsApp support, the tool they're already using every day. Check-ins can happen daily or can happen in a personalized way, whatever the user prefers, whatever works best with them. It can be linked to your escalation channels if required, in case there's a human that is needed, a human doctor. And the objective is very, very simple. Really improve daily adherence. It's also important to understand that we try to measure leading indicators. So things like how consistently does the user engage? Do they just check it once a month, or are they really using it to support their behavior every day? Behavior signals. Are they failing on little goals that they set up together with the assistant? Are they succeeding in achieving them? And then self-reported stability of glucose for diabetes patients specifically. And then escalation patterns as well. Have we identified high risk and connected the user with the real doctor? Claims are usually the outcome, but the driver is everyday behavior. And then over time, usually at least 3 to 6 months, they translate into risk signals. So is there less volatility in readings? Do patients get support earlier? Are there fewer unmanaged complications and lapses when they, for example, drop their medication? And then over a longer period, 6 to 12 months, these are exactly the patterns that reduce preventable complications. And that's where you have impact on cost reduction. We as providers or insurance cannot really influence every single decision a member or a patient takes, but we can really manage the environment in which those decisions are made by offering them something they can use day to day and that can support them. So you can scan the QR code on this page. It will take you to a very short form to express your interest. It would take maybe 2 or 3 minutes to fill in that form. And then within 5 working days, usually faster, we'll follow up with suggestion to have a scoping conversation, usually a 30-minute Zoom call with you and your team to really understand what an engagement could look like with you. And then we'll also select one sponsored founding pilot partner who will be selected on the criteria that we discussed. How clear is the cohort? Are you ready operationally? And then how committed you are to really working with us on a 6-month basis to evaluate the difference for your member population. That founding pilot partner will be fully sponsored. All the costs will be completely taken by us for all your members. In parallel, we're also open to structured commercial pilots with as many partners as are aligned and willing to move forward. For the pilot, we really want to prioritize depth over scale. We currently have around 350 active monthly users. So people who are really engaging at least 4 times on the monthly basis. The human escalation is already there. The escalation goes to our doctors who respond immediately, especially if it's a high-risk case. So we have different kind of flags for different levels of urgency. Sometimes it can be offering them to book an appointment next week because, they're not sure what to eat. But if it's actually a risky complication, then it's an immediate response. And if you have a preference of your own escalation path, whether it's your own clinical team or it's someone in your provider network, that can also be done very easily.
From an underwriter point of view, what is the return on investment?
We don't want to overstate short-term medical outcomes. And so the patterns we'll be looking at and measuring in the pilot, and something we already seen on our patient population, is things like sustained repetition of goals week on week. We are seeing people are able to, 50% of them are able to really sustain it week on week, which I think is quite exceptional when it comes to things like nutrition. How many people are able to restart successfully? Glucose stabilization as well, where we also seen very, very good numbers, trajectory day over day. So if someone is really struggling and forgets medication, they will get those reminders and they will get it at the time that works for them and also in the language that works for them. So some people prefer to speak to an expert, really a professor, kind of doctor. Others want to speak to a peer, a trusted friend. So that style is also adapted based on individual preferences because we wanted to really support them to actually change behavior and not just send 20 reminders a day.